Welcome to positioning of the calcaneus and the ankle. For the calcaneus, we're going to concentrate on the two positions that are in your book, plantar-dorsal or axial position, which is also called the tangential view. You can use a 10 by 12 for this. You're going to need a piece of tape to wrap around your patient's foot, and you're going to place the image receptor right below that foot. So dorsal flex your foot so the plantar surface is going to be perpendicular to your image receptor. You're going to use that tape, wrap it around the sole of the foot to pull those toes back. Your central ray is going to come in at the third metatarsal. You're going to put a 40-degree angle on that tube, so make sure that you measure out your SID. Because of that extreme angle, your SID's going to look off. So make sure you measure that SID to 40 inches. And you're going to set your technique between 65 to 70 kVp and 5 to 10 mass, depending on if you're using DR or CR. So your image is going to look something like this. Central ray right through that metatarsal. You're angling 40 degrees towards the head. Make sure that you've applied the lead apron. And your image is going to look something like this. So no rotation, you're collimated down to just the calcaneus. You're going to see that open talocalcaneal joint. So you should be able to see that right across here, and that systemical tala in profile medially. Your lateral calcaneus, patient's going to lie on their side with their plantar surface perpendicular to the image receptor, so your foot's in a true lateral position. Central ray will be perpendicular and 1 inch inferior to the medial malleolus. Again, technique is about 65 to 70 kVp, 5 to 10 mass. You don't need as much on the lateral because you're not going through as thick of an area. So medial to lateral projection, you're going to collimate down just so that you have part of the tib fib, and collimate down so that you have all of the calcaneus on your image receptor. Your image is going to look like this. So you'll see a portion of that talus, you'll see that subtalar joint, and you'll see all of your calcaneus. For your ankle, there are 3 positions that we're going to concentrate on. You're going to use, again, the 14 by 17 DR or 10 by 12 with your patient on the table. You're going to have a lateral malleoli and medial malleoli so that they're parallel to the image receptor. Your central ray is perpendicular. You're going to point it halfway between the malleoli. Technique is going to be 60 to 65 kVp at 5 mass. So your patient's going to look like this. You're going to then ask them to take their toes, pull them all the way back up so that they're dorsal flex, but don't over dorsal flex or your toes are going to fall right on that joint. You're going to see the distal 1/3 of the tib fib. No rotation. You see medial and lateral malleoli are in profile. You're going to have some superposition of the distal fibula. So over here you'll see that that is going to be superimposed, your fibula over your tibia. You're going to collimate down to the skin margins, but leave it nice and wide lengthwise so that you get enough of that tib fib so that you don't miss a fracture. Contrast will be a narrow dynamic range. You'll have optimal density. You should be able to see those trabecular markings. Your ankle Mortise view is the oblique that we're going to do. The 45-degree angle is not one that's commonly used at the hospital, so we are going to focus on the ankle Mortise, which is a 15 to 20 degree rotation instead of that 45 degrees. What we're trying to do is to open up that lateral medial Mortise joints. So here's one with the slight rotation of 15 to 20 degrees, and the other one over on your right is going to be 45 degrees. So some hospitals do the 45 degree, but the majority of them do the 15 degree. So the ankle oblique is the 45 degree rotation. So they will specifically ask for the Mortise view if they want a 15 degree ankle. So you're going to medial oblique, rotate the leg and foot medially 45 degrees, dorsal flex your foot so you're pulling back those toes. Central ray is going to be to the mid malleoli. If they order a lateral oblique, this will be done. It's an external rotation at Covenant. You are going to rotate that leg 45 degrees laterally Dorsiflex your foot, center again between the mid-malleoli. So the Mortise is what I want you to do for lab, and this is what you'll concentrate on for your positioning sheets. Halfway between the malleoli is your central ray, right on that joint. The 45 degree you need to be aware of, but understand that most of your hospitals will not use that one. You're going to open up that distal tibular fibular joint. Your lateral malleolus and talus joint are going to be open. Make sure that you have evidence of collimation on your film. You should be able to see through that subtalar joint, and your calcaneal sulcus should be seen. Lateral ankle, medial to lateral is your projection. It must be in a true lateral position, so dorsiflex your foot and support under the knee, so you can put a sponge or a towel or something underneath there if they need it. Central ray is going to be perpendicular to the medial malleoli. So on here you'll see that they're rotated. We're doing a medial to lateral projection. We are not going to do the lateral to medial. The only time you're going to see that done is the trauma situation where your patient's on a stretcher and you're going to shoot through the opposite direction. For your lateral ankle, you're going to have the distal 1/3 of the tib fib. Your tuberosity of the 5th metatarsal should be seen. Your talus and calcaneus will be in profile. The distal fibula will be superimposed. You'll see evidence of collimation. Make sure that your marker is on that film and that you have a narrow dynamic range and optimal density or brightness of your film. Stress views are the specialty views that you may see done. You're going to have inversion and eversion done on that ankle joint. We use this for ligament damage. You're going to center directly to the mid-malleoli, and your physician will come in and they're actually going to rotate those ankles, and you're going to take the picture, so make sure that you have lead gloves available for them. So if they have a joint separation or a ligament tear, they've had repeated ankle injuries, sprains, they're going to do these views.